morning, everyone. Again, this is your radio in New England for QIN-QIO. Thank you for joining us and in the detail of what I'm doing carefully. I'm just going to go to few housekeeping items. This call will be recorded for training purposes. Some pages will on the page if you have important chat. Online will be the presentation. Please note that I know that presentation is a little cut off. You can apply at the left-hand side of the presentation window to adjust your screen accordingly. You can actually chat or remember to send to all participants. And you run like if you have any buttons, you can use that. At this time, I use all lines. Okay, they're already in. I will now introduce speaker, Joshua Burnett, and Three McLaughlin, both is in the link with QI. So Burnett has ability improvement to the end, which is skills to technical and on-site work in nursing homes participating in math contract is all quite collaborative in Massachusetts. He is teaching person by turning data into access permanent. He's a licensed nursing straight in Massachusetts and Rhode Island. Marguerite McLaughlin is consultant contract advisor. I was Vice President of Education and Relations, Rhode Island Care Association. For that, she's the native Galaxy Director of Quality Performance at the American Healthcare Association. She served as co-director of Special Needs Care Unit before moving on the Alzheimer's Association of Rhode Island. She has about 20 lives as resident in long-term care centers. I develop educational research and product and consultants of quality at nursing centers. This is the updater both locally and national for chain healthcare. 30 plus experience, so with the insights and some experience in helping organizations care and their residents. She has served as liaison to the Industry Partnership for Healthcare under the Governor's Workforce Board in Rhode Island. In this role, she provides solutions to bridge the skills gaps within the healthcare industry. And now I will pass the ball to Josh to begin our presentation.
All right. So the data of the details. A twist of the phrase "the devil is in the details." In this lively, action-oriented webinar, participants will have the opportunity to deconstruct the process that leads to improvement in quality measures. In this example, we'll be focusing on antipsychotic medications. We'll walk you through the step-by-step QAPI process that makes improvements such as these possible. High levels of QAPI competency directly correlates to financial and star rating success and improves the quality of resident lives. We encourage everyone to be active participants in this webinar, so please feel free to unmute your line if you have a question or pose a question in the chat box. With the webinar today, we would like you to work alongside us as mentioned. So that we want to start with our first task. How would you rate yourself with QAPI? In the chat box, please type in your zip code and then rate yourself on your confidence and conviction based on a scale of 0 to 10. 0 being low while 10 being high. Please share your thoughts. Using the scale, It can help us pinpoint areas in which to focus. If our confidence is really high in our QAPI process, what does our conviction look like? Are we really motivated to utilize the process? Are our fellow leaders and interdisciplinary staff members sold on QAPI? Do you have the buy-in from the key players in your facility? Conversely, you can have the conviction for it, but perhaps lack in the confidence of the program itself and the methods behind it. Be sure to reflect on this and keep that in mind as we move throughout the webinar today. QAPI fundamentals and the overall process has been a highly discussed topic. This is primarily due to the new requirements of participation with Phase 2 implementation, which enforces QAPI within the regulations, thus ultimately enforcing surveyors' expectations of a comprehensive QAPI program. Speaking with several nursing homes throughout Massachusetts and other states already this year, a few of them have stated that surveyors had criticized and were even cited on their QAPI program not performing up to standards. Learning how to properly format your QAPI program to utilize the systems approach will help you become more successful in your quality improvement efforts. I also want to mention why antipsychotics have been at the forefront of our work. Since the launch of the National Partnership to Improve Dementia Care, significant reductions in the prevalence of antipsychotic medications used in long-stay nursing home residents has been documented. The National Partnership continues to work with state collaborations and nursing homes to reduce that rate even further. Recently, Centers for Medicare and Medicaid Services had announced a new national goal involving a 15% relative reduction of antipsychotic medication use by the end of 2019 for long-stay residents in homes with currently limited reduction rates. CMS has then asked the quality improvement organizations to work with the nursing homes on reducing antipsychotics. The best way to do that is through a QAPI approach. Additionally, practitioners skilled in QAPI are far more likely to identify and respond to issues and challenges that directly affect the bottom line. When administrative staff are aware and visual using their data as a power source, they are far more likely to realize financial savings. Think of it this way. If you're watching your data and reacting to it, you're much more likely to minimize your risk for fines, citations, notice any coding errors, and you'll be much more swift in identifying and responding to issues and challenges. So now that we understand why QAPI is important and why we need to work on antipsychotics, let's dive a little bit into the QAPI process. For me, here's an easy way to look at it. It's 6 simple steps. First, look at your data. What's your data telling you? Do you have a high antipsychotic rate? Are you experiencing a lot of falls? Take a minute right now and type in some of the places where you receive your data, either through Casper, survey responses, complaints, resident council. Step 2, engage your staff in the issue. They know a lot already about the problem. What do they think is causing a high antipsychotic rate? What's causing the number of falls? Ask them. A good way to do this is by asking and adding their thoughts to the root cause analysis and the 5 whys. Step 3, sort through the ideas and determine which are broken systems versus low-hanging fruit. Low-hanging fruit meaning quick, easy wins that you can simply fix so that don't require a performance improvement project. For example, a fax machine might be impeding the results of any lab results, and by fixing that, you'll be able to solve the system issue immediately rather than an elaborate project. With step 4, you determine the actual problem that you need to address and begin to form a plan. Step 5, pivot. Take the problem and plan your strategies. Do the actions necessary. Study a process to see if the changes are creating improvement, and if not, tweak it to do another PDSA cycle based on what was revealed. Lastly, step 6, spread your good work throughout other units of your facility. Fortunately, due to the error, there's supposed to be a picture here, but to give you an idea of how this works in real life, I've asked one of our Massachusetts homes if we can share their story. But let me first tell you a little bit about what they did using a QAPI approach to reduce antipsychotic medications. Belmont Manor's baseline rate for antipsychotic medications was 21.15%, and as of quarter 2, 2018, their rate is now 16.3%. Over the last 2 years, Belmont Manor has totally eliminated antipsychotic medication use from 25 long-stay residents, and as we know, falls can be often associated with antipsychotic use. As a positive result of their project, the facility experienced only 2 falls during the month of July 2018. Let me invite the Belmont team, Mary Murray Carr, the Director of Nursing, and her staff to help jump in and tell their story. Mary, go ahead. You can press *6 to unmute yourself.
Can you hear me?
Yep, good to go.
Okay. Hi, Josh. Hi, everybody. Thank you for asking Belmont Manor to come and share their success story. And thank you for the nice introduction. Belmont Manor, we looked to find the root cause of a lot of the behaviors that the residents were experiencing. We used a learning circle approach using about a 10-member team, including all disciplines, including nursing, rehab, social service, activities, and dietary. And we would focus on each individual resident to come up with a list of possible causes for the behaviors. We would then include the CNAs because we know that it's difficult to get everybody together at the same time, but we would bring this information to the CNAs to get their input. The team would then decide on one approach to resolve the behavior. And if that didn't work, we would go to another one. Oftentimes we were doing 2 or 3 different trials before we came up with something that was successful. We also, in addition to that approach, we provided a lot of education, staff education on behaviors and the use of antipsychotics. And we included the doctors and the nurse practitioners in that as well. We really tried to emphasize that behavior was a means of communication to the residents, and this approach put the residents first. And we were able to follow the residents, evaluate them, and come up with whether we were successful with those interventions or not. We also used a behavior log that we somewhat developed here, and we felt that that was successful in identifying what was working and what was not working. We also really tried to focus on the fact that if medications were needed, we looked to use different classifications of medications, maybe some that were safer alternatives versus antipsychotics. Another avenue that we really felt that we needed to focus on was family education. And we even invited them into some of our PIC discussions and to try to get them to understand the process of reducing antipsychotics. And I think probably one of the most successful avenues that we used was using our consultant pharmacist to help with the recommendations to decrease antipsychotics and our geriatric psychiatrists. We have rounds every month with the team, and we would discuss the behaviors of the residents and to attempt a possible reduction to the antipsychotic. We then realized that we were very successful at not only reducing the antipsychotic dose, but also eliminating it altogether. Another valuable tool that we felt that we came up with was what we call a get-to-know-me tool. And this is completed for each resident that comes into the facility, and it's extremely valuable for the residents that have dementia. And this tool speaks about different information about this individual resident, their likes, their dislikes, perhaps what their hobbies were, what type of employment did they have, places that they traveled, are they interested in sports, or whatever interest that they had. And we would really be able to capitalize on those avenues for that individual specific resident. And we actually asked the families to help us with those tools as well. And it not only was a successful tool, but it helped to build trust with the families, and sometimes often reducing guilt that the family members may have about bringing their loved one into a facility. So we also obviously have to involve our staff in all of the different involvements and techniques and interventions that we tried. And in the end, as Joshua said, we found that we were identifying two areas that we wanted to make improvements on. And we have been successful. We will continue to use this format to continue to reduce our antipsychotic rate. And as a perk, we were able to reduce our fall rate, and which is always very, very positive. So that's what I have, Joshua, and I want to thank you for inviting the Belmont Manor team, into this QAPI, PIP way of looking at things, and to have a positive outcome. Thank you.
Yeah, excellent, Mary. Thank you so much for sharing your amazing story and making yourself available so that the team might be able to ask you some questions. So let's, if anyone has any questions for Mary while she's on the line before we move on, feel free to put them in chat, or if you want to unmute yourself with *6 to pose a question for Mary, now's the great time to do so.
I have a question. How large of a facility is Belmont?
435 beds.
Okay, thank you.
We had a question in chat. Would you be willing to share your Get to Know Me tool?
Sure. Sure, I would. Josh, if you, want to take the information and pass it to me after the webinar, I'm happy to share that out.
Absolutely. So we'll be able to reconnect and then be able to share that with our participants afterwards.
Okay.
Fantastic. Does anyone else have any other questions for Mary while she's on the line? She's a great resource to be able to, pick her brain. We have one last question in chat. Mary, how many performance improvement projects do you have going on at one time?
It's a little difficult to say sometimes, but maybe 4, 5, 6. I want to say like 3 at we might be in the meat of one, but I might pick up one because I know that one is coming to an end. So, but we don't do a lot because it's just us. We're a privately owned facility, and we're the ones that doing the legwork and heading the meetings and going to the PIP meetings and following up with what works, what isn't working. So I guess maybe 3 to 4 will be the better answer. Mm-hmm.
Right. Perfect. Thank you so much, Mary.
Welcome.
All right. So as far as the QAPI process, just to recap, you can see how the 6 steps approach that we identified earlier played out for the Belmont team. They used the data to inform them that they had a problem. They engaged staff and families in their solutions. They used a number of different strategies to sort and identify their various issues, and developed and worked on a performance improvement project until they arrived at success and then widely spread throughout the facility. Once your team gets the hang of doing this, it becomes easier and easier to create positive change and quality improvement. Let's take a deeper dive into the process, first looking at data gathering. So the first step is to always gather data. I recommend taking a look at your facility characteristics report. And if you were able to pull your facility characteristics in preparation for this webinar today, I encourage you to take that out and take a look at it. You can see the average gender, age group, percent of patients with psychiatric diagnoses, percent on hospice, your referral services, etc. Looking at your facility characteristics gives you a quick snapshot regarding the population that you serve and why you may be struggling with specific quality measures. Take a moment to review your facility demographics compared to the state and national ranges and highlight some of the areas that stand out. There are some hints that you can find which can better help provide a story for your quality measures. For example, if you have a higher than average young population and the percentage of patients with a psychiatric disorder, then that can also often lead as to why your facility may be struggling with antipsychotic medications in your quality measure report. Right now, look through your report in front of you and take a highlighter and mark the areas that stand out to you, things that are higher than state and national averages. What are you seeing? What are the irritants that are jumping out at you? In the chat box, write down some of the things that you see on your report and would like to share with us. So while we're waiting for some responses, I'd like to mention that in late 2017, health-centric advisors had transitioned to utilizing a ShareFile system to provide reports for the nursing homes. ShareFile is a cloud-based system in which facilities can log in and access the reports. While the data being reported via the reports that we provide are several old-month data, they can provide valuable insight into systematic issues related to your processes. Overall, the reports can provide you with information you need to ask the appropriate questions during a root cause analysis and provide you with the valuable data to help guide your facility's QAPI program. And lastly, as a reminder, as far as data, it doesn't have to be just numbers. It's any facts or statistics collected together for reference or analysis. So survey responses, resident council feedback, complaints, as mentioned earlier, are all valid means as well. So we have a polling question here. If they're able to implement it and ask that at this time, how are you sharing data with frontline staff? Have about 30 seconds to answer that. The options are through quarterly QAPI meetings, monthly quality meetings, staff meetings, performance improvement projects, stand-up or meetings, newsletters, or other. Let's see what everyone is able to share. All right, do we have the results for the poll?
Yes, we do, Josh.
Okay. Perfect. You see, most of them are through, everyone is not providing an answer, but we had a few people that had provided that they share a lot of their data with the frontline staff through staff meetings and as well as their quarterly meetings. So after we're going through the data reports to determine the areas of focus, I want you to now pull out your resident performance report. This is where we can see where each of the quality measures each specific residents have triggered for. I recommend taking a look at the number of quality measures each resident has triggered and make a list of the residents that have triggered 3 or more quality measures. You can see the number that they've triggered for on the quality measure count. This approach will not only help you hone in on issues on the same unit, but will work to maximize your standing on your 5-star rating. So here's a great example for you to see. Since we're working on antipsychotics, I've highlighted the antipsychotic measure and the residents triggering for them. Additionally, I highlighted the quality measures on the slide for residents who've triggered for 3 or more quality measures. So take a minute and highlight comfort and any residents that you see who triggered for 2 or more quality measures. I'll give you a minute now to go ahead and do that. All right, hopefully you're making your way through the resident level quality measure report. Many of the quality measures have a domino effect on each other, and when you improve in one quality measure, you can often see improvement in other quality measures. Antipsychotics often see other quality measures triggers such as behaviors, medications, and as mentioned earlier, falls. So highlight some of the other quality measures that the residents who are triggering for antipsychotics are also triggering for. Take a minute now to go ahead and do that and see if you can identify other quality measures that are also trending. In this example, I'm showing you that there could be a significant correlation between the residents who are on antipsychotics and causing them to fall. Other examples that I can share while you're going through it are perhaps residents that are looking for weight loss, also experiencing pressure ulcers, or residents with pressure ulcers, are they also triggering for pain? Additionally, if they're triggering for pressure ulcers, they could also be triggering for loss of control of bowel and bladder. So when you're working on your antipsychotics reductions, you can potentially see reduction in falls, and you begin to notice certain triggers seem to set trends amongst each other. Go ahead and share some findings of what you're seeing among your population and other quality measures that they may be triggering for alongside antipsychotics. And now I'll pass it over to Margie for her to talk about engagement investigation with staff.
Hi, everybody. So now it's kind of exciting because you've gotten all this data and you've pulled all this stuff together. Now our job is to actually go and talk with staff and kind of get a feel for what people's impressions are. So the antipsychotics, being able to bring that data right down to the frontline staff and say, hey, we really want to make a change here. You can see this isn't a good thing for us. So how can we go about? What are some of your thoughts? And there's a couple of ways you can do this. You can do something called a learning circle. And a learning circle is a means by which you get a whole gang of folks. And you put out the question, what do you think we can do for Harry because of he's on antipsychotic drugs, and yet we know that some of his behaviors are such that they make for some difficulty in our setting. And so what you do is you literally form a circle and put that question out. Give the CNAs and all the folks who are part of the circle Post-it notes, and they begin to brainstorm ideas. Here's how it works. One person can talk for 2 minutes without being interrupted, and then it's passed to the next person. They offer their ideas, their solutions, why they think it's happening, and somebody, either they can do it or somebody can be the scribe and actually write all of those ideas out on Post-it notes. And then you can just post them on the wall. And what you can do is once you've gone all the way around the circle and all those suggestions are posted, what people can do is actually go up and actually kind of rate how important it is. Or you can pretty much say, what do you think are the top 3 things that are causing it? And so people can go up and put like a little red circle on it or check it or whatever you want to do. The circles, little sticky circles, usually work really well because it helps people to stand out. What I want to tell you about this process is way in teaching. It's a great way to get people excited about being in the QAPI process. And whether you're calling it that or not, it allows the people to really have a sense that they're part of the team. And so we see that learning circles become a really important part of the story. And another really good tool that you can use, besides learning circles, you can do what we call a fish phone. Sometimes people get stuck on this because it looks kind of mechanical, but I'm a big fan of taking construction tape, the blue construction tape that keeps you from getting paint on your ceiling, and actually make a fishbone on the wall. And using Post-it notes, you actually get staff engaged in the process. At the head of the phone, what you actually put is a little sticky that is the problem that you're trying to solve, and then you literally put the bones, if you will, and name them. We're big fans of the Hatch model, so we use the bones. Often they'll say things, practices, environment, care practices, family, community, and regulatory. And then those become kind of like the way we kind of categorize or sort some of the responses that people give. So fishbone diagram, really great way to look at the process. Josh has a great example here that if you download the slides, you can use as a template. So using those 2 particular things, what you're basically doing is getting lots of people's feedback. Sometimes as quality equipment specialists, we go into the homes where there's kind of like a lone ranger, and they're the ones who have kind of more or less done all of the QAPI, and it's not being integrated onto the flaws and into the work of staff members. So we really encourage folks to engage with as many steps as possible in the process. This is a slide from Kim Jamaro, who helped us out a while ago and actually showed how they actually used went through their QAPI process, sorting out, thinking through how to resolve an issue that they had sent. And you can see how it's a big Post-it note, very colorful, gave a lot of opportunity for people to be able to move to the next step, to kind of see it visually. My friend Sandy Fitzroy always reminds me that people have all kinds of different learning styles, and so to make it as visual as possible for our visual learners, make it active where possible so that people can get up out of their seat and do some polling when they're in the process of the learning circle. All of those kinds of things make such a difference in making people feel engaged in the process. Once you've done all that, needless to say, and you can see from that diagram, there are lots and lots of ideas that come. And so what you want to get to do is kind of sort through some of those ideas. We've really done it by doing some of the polling, but more to the point, sometimes there are things that you don't need to do as a PIP. You don't have to do as a quality QAPI project. Simple things. Like if you know that the frustration and the biggest problem is that the fax machine is broken, so you can't get the doctor's orders, go to Staples. It doesn't need a PIP. Just run over to the store and buy a new one. The wireless not working right, just get a new one. Get a capital campaign thing going and just get a new one. Because PIPs are to actually help move and provide improvement to systems problems and to people problems. So those are the 2 important things to remember when you're faced with all the great input from other people.
Marty. So we've been through a couple of the steps already. When we look at step 4, the process when we get to after we sort through the various items, we're going to drill down and figure out why something's happening. One of the quality improvement tools is called the 5 Whys, and I'd like to talk a little bit about that more for some of you who may not be as familiar. So, remember, these are hypotheses in which your team will test during the performance improvement project process. You want to prioritize systematic issues and run them through the 5 Whys. Many of us have experienced the painstaking pleasure of having children, nieces, nephews, grandchildren ask us why constantly. This approach can be very crucial to understanding the root cause of an issue or a system. I always think of my nephews when they were little and would ask, "But why, Uncle Josh?" And everything I would respond to, I would get, "But why?" And back from them. Eventually, it sometimes gets to the point where it became "because I said so," and reflecting on this, that wasn't the proper response for me to give them. I know that sometimes we often have a bad habit of doing things just because, or stopping at the first couple of answers we are given, when in all actuality, we need to dig further. So I want to specifically share a specific example from one of the facilities that I've been working with as I attempt to reduce antipsychotics from a resident. The resident exhibited negative behaviors and anger towards staff, and the team had gathered together to discuss what they thought the cause of the resident's anger was. The team had thought that the resident was always angry because the resident consistently missed smoking times to go out and smoke. We had went through the 5 Whys and to find out why the resident was continuing to miss the smoke times because they were not up and ready early enough. We asked why, because the resident was angry and resistant to care, so they weren't able to get up. We asked, okay, well, why are they that way? Because the resident was soiled and was yelling to be changed and had set the mood for his entire day. So we had come up with a couple of ways that we could potentially improve this, and like making a small change to either have them being cared first, or potentially even titrate liquids throughout the evening and provide more during the day so the resident can actually have better outcomes in preventing accidents through the night. So, after you've conducted your root cause analysis, it's time to pivot. If you've downloaded the QAPI and performance improvement template provided on the invite for the webinar, I'd like to take that out now. So QIN-QIO has developed this easy-to-use performance project tool, and we've received a lot of feedback for those who formed within the QI program, and the application is had within the as well as the Department of Health request through the QA efforts. Very friendly, direct, so you're able to put information friendly. And if you would like more competency forms, you can reach out to your local Newman contact to provide. So we have an improvement project template. Let's go through it all together and have everybody formulate a performance improvement project, and we'll go through that together. The first question on the tip template is what the performance improvement project is called. You can be as creative as you want, come up with a funny name, to make it fun, or you can, for the purposes of the website, you can just say we're going to take some medication. So go ahead so that whatever you would call your performance improvement project. Next question asks who is the team? And I want to be specific because the name is not roles. It should be recognized on the performance improvement project formalization. The reason for this is because if you're just inflating positions, there's no accountability for the project and for the people who you intended to be on the project to continue on it. Additionally, it's important to know specifically and name them because need to allow them to have some time to work on this project. So as you're working on filling this out, think of a couple of employees within your facility that you feel might be a great interdisciplinary approach to work on the performance improvement project, and name them by name. The next question should ask us if there's any specific supplies or equipment that your team needs for a specific project. This is very important because it's mentioned 4 or 5 times in the new regulations that the governing body and executive leadership must provide adequate funding for QAPI and for performance improvement efforts. So if we're working on antipsychotics, there may not be any specific costs attributed to the specific project. But by acknowledging the question, we're showing that we're being in compliance with the regulations. You may have other performance improvement projects, such as falls, and as Margie mentioned earlier, with the Hoyer lift, that may require a capital expense. So we just want you to acknowledge for the specific projects. Let's see, in the chat, Florence, can you hear me? Anyone else hear me? You guys having difficulty hearing me? If you want to jump on the phone or share on chat if you're having difficulty hearing me.
Josh, I can hear you. It's very...
Okay. No issues. It might just be Florence. All right, Florence, got to go on. Not yet. So the next question, you're going to identify how often your team meets in a meeting schedule. You want to establish a consistent meeting schedule, either weekly or biweekly. And as Mary Carr had mentioned from Belmont, taking the staff off the floor can be really difficult. So we're not really encouraging you to set hour-long meetings every week. Really, all you need to do is a 5 or 10 minute stand-up, and really just gather the team together as you're focusing on a specific resident and talking about what the behaviors have been and what improvements have you seen from the changes that you've been implementing. So, quickly write down what you think might be best fit for your facility. This is a live document, so you can always go back and change it later on. Next, we're going to look at the data sources that you'll utilize to monitor the impact of the project and identify a few items that we're going to monitor. So a couple of things that we are, of course, going to monitor is the antipsychotic medications. But we could also monitor the behaviors as well. So if you're looking at behavior logs, you can have a baseline rate and take a look at and see whether any of your changes is actually resulting in a reduction in behaviors, because that's what's going to help you become more successful with taking these medications off these patients. One of the next questions is, who reviews the data and how often it's done? And is the change resulting in an improvement? You want to periodically check to see if it's working or if you need to begin a new intervention. Specifically, I've worked with facilities who pull the data on like a monthly or bi-monthly system, and I really recommend not waiting that long to be able to pull some of that data, because when you implement a change, you want to start tracking it and following it immediately, week by week, to see if those changes are actually resulting in an improvement. And the more time you wait to actually go back and review, the more time you would have wasted, because you could have found out that the specific change or intervention was not working. You could have tried something else. So next, we're going to document who is going to review the data and how often it's done. Actually, I just said that. Apologize. Who will and present the project results. More often I see leadership do this, but even better, I would actually encourage some of the frontline staff that you've identified for your performance improvement project to help consolidate and prepare some of that data to your QAPI committee. It's a really great way to get them, to empower them and engage them even further, and develop the leaders of tomorrow that we need. Next question on the tip template. If your project specifically addresses any protocols or procedures. So your facility might specifically have some policies or procedures in place related to antipsychotic medications. I've known of other facilities that have a policy in place where the director of nursing needs to be notified before any antipsychotic medication is added to a patient. More often than not, the facilities I've worked with, initially, they had tried to stop this project only to find out that a nurse had called the physician and got a new order for the antipsychotics while they're trying to reduce them. So it might be worthwhile to potentially put in a protocol where your director of nursing is first notified. The next is the problem-solving methods that the facility is going to utilize. So the PDSA, for example, is a great thing that we're going to talk about in a little bit. So I would really recommend that. It stands for Plan, Do, Study, Act, and it's used to implement small tests of change. And lastly, the root cause analysis method that is utilized. As mentioned earlier, you can utilize the 5 whys, and as Margie had mentioned, the learning circle or the fishbone diagrams. Just fill in and acknowledge what you're going to be utilizing for the root cause analysis. With that being said, your performance improvement project template is completed. And like I mentioned earlier, it's a live document, so we can always go back and change it. So when we look at the actual model for improvement, it makes use of a rapid trial and learning method that relies heavily on taking action. The diagram I'm going to show you demonstrates this method. And the first question you should always ask is, what are we trying to accomplish? In this instance, reducing our antipsychotic medications. That is setting our aim. The next, we want to establish measures. So how will we know that a change is an improvement? We can see this as we're tracking the antipsychotic medications to see a reduction in the medications. Again, with the behaviors, as we're monitoring our behavior logs, we can also see if the changes is resulting in fewer behaviors. And lastly, we want to actually make the change that will start to see those improvements. So here is a quick rundown of the Plan, Do, Study, Act. You want to propose your change idea, predict what will happen, implement the change idea and collect some data, reflect on how that plan was followed, analyze and collect and capture your learnings, and finally, conclude whether to adopt the change that you input, adapt it to some of the variables that might have occurred during the time, or abandon the change and start a new one. So I know we're running a little bit short on time, so I'll kind of skip through a little bit of each one of them and get to the actual model itself. So if there's anything to take away aside from formalizing the performance improvement project is to keep this in mind. Set your aims, set your measurements, and then your change ideas, and then implement those through the Plan, Do, Study, Act cycle. Once you've done that and achieved success with those residents, you want to move on to other units throughout your facility and try to work with more of your residents that are also experiencing a high antipsychotic utilization rate. And I want to share this quick picture with you guys before I go, courtesy of the Iowa Healthcare Association. As you know, part of the QAPI regulations requires that the facility communicates QAPI efforts with staff, family, and residents. So this is a great way for this to be achieved in multiple ways. Either through newsletters, care plan meetings, or resident councils and staff meetings. But this of actually having a QAPI board in a public space is a great way to be able to hit all of those different populations to inform them of what your QAPI efforts are in the facility. So as we wrap up today's webinar, I invite you to share your confidence and conviction again towards QAPI on a scale of 0 to 10, 0 being low, while 10 being high, in chat with what we have just discussed today. Hopefully you're able to walk away with this webinar a bit more confident as far as the QAPI process, and the QIO is there to help you individually with any technical assistance that you may need, depending on your level. Do or do not, there is a try. Does anyone have any questions before we wrap it up?
Okay, thank you, Josh, Barbie, and Mary for a great discussion. I have a few last announcements before we end today's call. Josh, can you pass me the back, please?
Sure. There you are.
Thank you. Okay. The new English Antipsychotic Collaborative Award winners will be selected following the new year. You still have time to submit your facility success stories before the December 31st deadline. Your student will receive a ribbon, either blue or gold, to display along with your badge. Acknowledge their accomplishments during the collaborative. The new program leaders will determine the criteria listed on this slide, including your submitting a best practice or success story, which is as easy as filling out a 5-minute survey that I'm going to post the link in chat. Okay, a big thank you to all facilities across New England for their commitment to quality. Here are just a few of the many teams who posted their quality commitment badge in their front entrance, posted and tagged the QIN-QIO on Facebook. Make sure you take a photo and share with us on social media so that we can celebrate your commitment as well. You may be highlighted in the future QIN-QIO webinar or newsletter. As always, your nursing home team is available as a free resource for you as participants of the New England Nursing Home Quality Care Collaborative. For support on your quality improvement initiative, contact information to your QIN-QIO Nursing Home State Lead is listed here on this screen. Thank you for joining us for today's webinar. Have a great rest of your day.